Okay, I think you should be ready to go.
Okay, all right, we'll get started here. Just to, before we get into our education part of the meeting, I just want to put a pitch out there for our elections. These will be for the next year's board position. And so we have 3 board member positions that are available, and then also the secretary position and the president-elect position. And so all of those are 2-year terms with the exception of the president-elect position. That's a 3-year term. You serve it as president-elect, president, and then past president. And just getting involved with the board is just a really good way to kind of share your ideas with the membership at large and kind of add your voice to see how we can best serve our membership. So for me, this is my first year that I've been on the board. And it's been really rewarding to work with an awesome group of people and really be able to kind of guide the direction of our local chapter, which has been really fun. And then also, it's just been a good growth opportunity, especially this year with COVID and everything, being able to kind of do some creative problem solving, we'll call it that. So I just want to throw that pitch out there. If you're interested, you can get in contact with me. And then additionally, we're going to send this flyer out after the meeting, and it'll have my contact information on there. And with that, I will turn it over to Tati to introduce our speakers for today.
Oh, actually, I was going to share the screen. Let me share the screen first before I forget. Find it too. Okay, Don, you should have the screen now. So as they are getting set up, it's our privilege to hear from Dawn and Sherry. They're going to talk a little bit about their COVID-19 and their experiences that they have. So a little bit about Dawn's background. It includes more than 30 years in surgical services, working in various roles from environmental technician to scrub technician to circulating nurse. And after serving 5 years as the sterile processing department manager, Dawn transitioned to infection prevention, where he has been for nearly 5 years. He's a Montana native, and he has lived in southern Idaho since 1990. He currently resides in Twin Falls, where he's a proud grandparent along with his wife of 37 years. Sherry Tolley is an infection preventionist for St. Luke's Health System. She has a microbiology background and has been working in infection prevention for 4.5 years. She has worked with ambulatory service line and is currently working as an infection prevention in acute care areas. Along with 2 other RPs, she covers 3 facilities, 2 CAS in Jerome and Wood River and Magic Valley Regional Medical Center. She has been working with the Magic Valley Antimicrobial Stewardship Team, the Bug Squad, for more than 15 years, first as a microbiology representative and now as infection prevention. So we are eager to hear from you if you want to start your presentation.
Thank you, Tati. Appreciate that. Sherry and I are part of the infection prevention team for the St. Luke's population health area that includes Magic Valley, Jerome, and Wood River. Today, Sherry and I are going to share some personal insights from our experiences during the early part of the COVID-19 pandemic. The objectives that we will be covering today, we're going to have a brief discussion of some of the mistakes that we've identified and lessons learned. We're going to address both victories and barriers that we encountered during this journey. And finally, we'll wrap up with some ideas for readiness and preparedness moving forward in a world that now has COVID in it. At this time, I'll turn the time over to Sherry, who will discuss our beginning timeline of events.
All right, so the time period that we are discussing today is indicated by the red circle. It is the middle of March through the first part of April. So this little blip that's circled there represents the Blaine County COVID-19 outbreak. So March and April 2020 will mark for me as one of the most stressful, busy, challenging, but yet rewarding periods of my career to date. So for me, this started while I was on vacation in Hawaii. While there, I was watching the news about this new novel coronavirus from China and the few cases that were in the US. And as I watched, I had this sinking feeling that this was going to have a huge impact on me and my work when I returned home. And as things escalated, I worried even about getting home. Then on an all-night flight home, I saw several people with masks, and I was wishing I had a mask. And I listened to the lady behind me and another baby cough and hat for 5 hours, and I thought to myself, I could come home with coronavirus, and that kind of worried me. And then there were so many questions, like, how deadly was this virus? How do I know if I have it? And if I have it, how long will I be out? So I flew home on February 28th, and I was super worried. When I got home, I vigilantly watched for weeks, trying to detect if I had any signs or symptoms. And at that time, we didn't know hardly anything about the symptoms that it present with. So, thanks, Tom. So on March 1st, I started to take call. I guess you could say I drew the short stick. Because on March 3rd, I started to get calls from Wood River. There weren't specific patients, but they had concerns because of the population up there that travel frequently and have alternative residents out of state. And then on March 6th, we were actually presented with patients that they wanted to test these patients. Well, this was a challenge because we all know that testing availability was not great those first few months. So we had to go through the health department, and they were only testing symptomatic individuals with a travel history. And at this point, we weren't even certain about symptoms. So I actually attended in person a meeting at Wood River on March 10th, and the possibility of a COVID-19 outbreak dominated the discussion. With the demographic in Sun Valley, we knew that they were at risk. And by March 6th, I was getting several calls a day and night of patients that they wanted to test. So we will talk about some of those challenges in a minute. On March 12th, we finally had our first confirmed positive. So this was a lady that had no travel history. She presented with pneumonia and diarrhea, and she tested positive for C. diff. So we thought she had diarrhea because of C. diff. However, the Wood River physicians insisted she be tested because her digital images looked like COVID-19. So we tested her, and we waited several days for results. She was admitted and had been transferred to Magic Valley. Several days later, we found out that she was positive. And she had attended a large wedding with guests from out of state. And then at that point, we realized we probably had community spread. It was determined there were several events that played a role in spreading COVID-19 to members of our community. And those that had traveled to Sun Valley for these events. So there was the National Brotherhood Skiers event at the Sun Valley Lodge that included hundreds of people and a large wedding. And in the first few weeks, almost every case identified had some sort of ties to those events, even our employees that tested positive. So we started to see more and more patients that required testing, but testing wasn't available. On March 17th, we stood up our drive-through testing in the hospital parking lot. But at this time, we were waiting 7 or 8 days for test results. And the disease spread quickly amongst our hospital staff. And the ones that weren't sick were out on quarantine for 14 days due to high-risk exposure. This really affected our staffing, and on March 20th, we had to suspend Wood River services. We kept just the emergency room open and began transferring all inpatients to Magic Valley Regional Medical Center, which brought on a whole bunch of issues because we were transferring possibly infectious patients and the logistical problems that had to be handled. So I wanted to show this slide because it represents our Magic Valley ICU surge. So we quickly realized that we weren't going to have enough negative air pressure rooms. So following CDC guidelines, we decided that our cardiopulmonary unit would be where we would cohort COVID patients that did not require critical care. But as you can see from this slide, our ICU was pushed to capacity those first few weeks in April. And you can see that's indicated with the red circle in the bottom of the slide. And then the light blue line, that represents how many people we had on the ventilator at that time. There were actually 2 weeks that we spilled over our ICU and had to send some patients to Boise. So now we're going to talk a little bit about the mistakes we made and what we learned during this situation. So first mistake, so we learned adherence to isolation and standard precautions is a must at all times, not just in a pandemic. We knew that Wood River was loosey-goosey with their isolation on our influenza patients. This was a huge concern to us, and we had reason to be concerned. We taught cover your cough and mask patients with respiratory symptoms, but we knew that it was not happening all the time. Not just in Wood River, but some of our other facilities. Well, we can see how that panned out.
The second mistake and lesson that we learned revolves around stay in your lane. We experienced that when caregivers are unsure of what to do in the face of an emerging pathogen, they call infection prevention. All of a sudden, we're the subject matter experts on everyone's list. Well, one of the mistakes that we made and have since identified is that we allowed ourselves to be drawn into situations that very quickly could lead us out of our role. For example, in the beginning, all testing was being conducted by the health department, and there were very strict guidelines as to who could be tested. We found ourselves drawn into the middle of the conversations between providers on the one hand and the health department on the other around who should and should not be tested. We were also fielding phone calls asking for permission to test, who we then referred to the health department. We found ourselves stuck in the middle, and asked to make decisions that should have been made either by the health department or the provider and not IP. So that was a very, very powerful lesson for us, is to stay in our lane.
We also learned to share the load. So before COVID-19 hit, our IP team would each take call for 1 month at a time. I started March 1st, and I took call for 16 days straight with the highest volume of calls we have ever experienced. I should have used my team to share this load because I got hammered. I have a great team, and they would have been more than happy to help me shoulder that burden, but I waited way too long to call for relief.
Another lesson that we learned from this was that oftentimes taking a pause before rolling out a change in practice or process is a valuable thing to do. Ask the questions, are all the pieces in place? Have all the stakeholders been included? In the beginning, even though we had strong leadership and some very good elements in place, we still had struggles with changing processes, guidelines, recommendations constantly changing, especially with the implementation of some of the processes. For example, when the CDC updated recommendations for extended use and reuse of N95 masks and eye protection, we put into place collection and storage processes. We had clean and dirty collection totes that were distributed to the units without instructions or rationale. From the staff perspective, imagine these totes just appear right on the floor with no guidance and with unclear expectations about the use. Had we paused, even for an hour, to include the different affected stakeholders and develop a more comprehensive plan for implementation, many hours would have been saved in rework and a lot of confusion avoided or eliminated by combining education for the process to the frontline staff.
Another thing we learned was PAPR only does not work. So before COVID-19, it was decided that Wood River would be a PAPR only facility and that staff would not be fit tested. So this had been identified as a risk, and we were working on the situation, but we quickly realized that we were not going to have enough PAPRs to protect everyone. And during a pandemic is not the time to resolve this issue.
With those thoughts in mind, we want to share some of the victories and the barriers that we encountered. The victories that we'll talk about here is, first of all, infection prevention is part of incident command. Subject matter experts are an integral part of the incident command structure, and Sherry was our incident command liaison and the subject matter expert for leadership. This allowed IP input into the decision-making process and proved invaluable for our ability to ensure patient and employee safety. The second victory that we count is that we had tremendous support from our system. This, in particular, is a call out to our system level leadership on all levels, but especially with our infection prevention leadership. If we ever had questions, and believe me, there were a lot of them, we had essentially a direct line to our system level leadership. They always fielded our calls and provided timely feedback and answers as we needed it. The third takeaway or victory that we had was the countless examples of comprehensive teamwork across our system. I cannot count for you all of the examples that come to mind. They're just very, very numerous. But I'll hit on about 4 or 5 just to kind of illustrate what I'm talking about. We had staff that were willing to travel to fill in for gaps caused by quarantined or absent staff. And so we would have folks traveling from Twin Falls to Wood River and just to fill in the time. We had displaced staff that were stepping up to be trained and function as safety monitors in our cohort units. We had our quality team members that stepped in to help manage that safety monitor scheduling, training, and deployment. And we also had quality team members that stepped in to help review positive COVID test results and gather data for reporting to the health department. I cannot express my gratitude for the collaboration that we had, because it was really key in our ability to handle and manage cares through the surge. I'm sorry, let me tap back just a minute. I transitioned a little bit early. One of the victories is the lessons that we learned from Wood River. With the examples that Sherry referenced just a minute ago of staff-to-staff transmission and the results of loose adherence to standard and isolation precautions fresh on our mind, we worked diligently to tighten up processes around those issues. We worked with EMS, for example, to utilize appropriate isolation precautions during transfer. We worked to mask symptomatic patients at all of our points of entry, especially in the emergency department. And we have an increased, never-ceasing emphasis on hand hygiene, and we've had tremendous results from those efforts, amongst others. And the last victory that I'd like to highlight is that COVID-19 has really highlighted the importance of infection prevention principles for our staff. In my experience prior to the pandemic, infection preventionists are often perceived as pests, right? Flitting from place to place to bug the staff about things like proper PPE use. Hey, take your shoe covers off before you come out of the OR, that kind of thing. Cover your cough, wash your hands. Well, if there's one takeaway that I would encourage you to know and own, it's this. Emerging pathogen, global pandemic, notwithstanding, we've got this. We have the tools, and more importantly, the knowledge and the principles to handle anything that comes our way. The basics are the key. They are foundational principles because they work, regardless of the name of the organism or how much we know or don't know about a disease process.
All right, I'm going to talk a little about the barriers we encounter. This is just a few. There were a lot. So first barrier was testing and resulting capabilities. And I'm going to include in this data collection. So we all experienced the challenge of the lack of testing in those first few months. So I'm not going to talk much about that. But there was also the ability to result the test once we had the results. We could not enter them into our electronic medical record. So we had to figure that out. We didn't have the capability to pull reports from our EMR. We couldn't even pull a report about how many COVID positive patients we had in-house. We spent countless hours just developing ways to track that data. And then also, as many of you know, or probably all of you know, There was the supply chain disruption and the PPE availability. I think we all felt that pain. And it really highlighted to me the importance of stockpiling critical items when possible. One thing that saved us with N95 masks was that we had our Ebola stockpile. We had a trailer that had emergency supply equipment that had gowns and N95 masks, and we were able to go to that stockpile and get quantity sufficient so that our staff could have N95 masks. Also, one of the barriers we had was this was a new virus. We had tons of questions and did not yet have answers. So a lot of times we were going by our gut instinct based on what we knew about infection prevention. And it was a struggle. And then another thing that we had was we had to respond in real time. So first I want to say our system was awesome and very supportive. However, it was a struggle. When we were waiting for decisions to be made at the system level, we had patients right in our hospital at that moment that we had to take care of. And we had to decide the best way to do that. So making those decisions in real time was really scary. And also, there was the constant change in CDC recommendations. Again, this is a pain that I'm sure has been felt by all of you and that we continue to struggle with. But as we learn more about this disease, those recommendations are going to continue to change.
And finally, just a few thoughts to share on readiness moving forward. How do we prepare ourselves for the next time something like this happens? Well, the first principle that we would propose to you is don't drift. In the words of the immortal Mad-Eye Moody from Harry Potter fame, constant vigilance. Be ever vigilant to teaching and reinforcing the application of infection prevention principles. Those principles will save lives. The second thought that we would share is what supplies are necessary to be ready? Are we prepared? I think it's safe to assume that every organization will be reevaluating our pandemic readiness plans and redefining PPE stockpiles and what we need to do to be ready. The third is good working relationships between employee safety, employee health, and infection prevention. That triumvirate is absolutely key. Those relationships nurture, develop, and protect them. We've worked, and I'll ask you ahead of time to pardon the pun, literally hand in glove with these partners as we've addressed numerous safety issues, conducted contact tracing, and worked with trying to get our head wrapped around all of the things that were going on. One of the big perks that has come to us through this pandemic is the honing and tuning of our employee-patient exposure process.
The fourth thing is know your health department. Involve them in your IPC. Have a good working relationship with them and know who to call and how to get a hold of them. Their knowledge of what is happening out in the community is imperative when planning for possible surge. The next is study the principles of incident command structure and have trained staff. This was a tremendous help to us at Magic Valley. Our leadership in incident command were all experienced and had been trained. So we got a lot of calls from other facilities asking us, how do we set up incident command? Well, there's a training on the FEMA website, like an online training that you can use, but also take advantage of the FEMA training, the in-person training that's available in Anniston, Alabama. So our facilities had sent staff to that training, and that experience was invaluable during this time. The last thing is have drills and involve providers and front staff. We know the key to being prepared for any emergency situation requires practice, practice, practice. As you can see, we learned some hard lessons, but the number one thing I took away from this whole experience was a great appreciation and admiration for our staff and administration. So many people stepped up and really worked hard, from countless hours from our administration and incident command to our providers and our nursing staff who were sent to train in other departments, down to those nurses in ICU and our cardiopulmonary and emergency departments that are still working day and night today, providing quality patient care to possibly infectious patients without complaint. We really worked with a great team. So, thanks.
And at that point, we'll open the floor for questions.
Don't forget to unmute yourself if you would like to ask a question, and feel free to use the chat as well.
This is Cindy from St. Luke's, and I just want to thank both of you for sharing. I know it was a difficult time, but listening to how you went through all the processes was really interesting, and I appreciate your sharing of that information.
Thank you, Cindy. Appreciate that.
This is Terry, and I think we probably had the same learning, lessons learned over at St. Al's, and I liked your comment about, Don, about the basics of infection prevention. Any kind of outbreak investigation or pandemic, it always comes down to the basics, that people forget the basics of infection prevention. So thanks for pointing that out. I did have a question. You know, you said earlier that at Wood River, the staff weren't very good about using precautions. And so you trained them and got them on it. Are you finding anything now, later in the game, that staff are starting to become lax again with wearing their masks and any exposures?
I think I can speak in part to common experience, and that is, as we become familiar with something, or it becomes part of our normal routine, we become less adherent or less vigilant in how to properly use it. And masking is no exception. You know, prior to the pandemic experience, I can tell you that we would routinely talk to people about, hey, remove your PPE before you come into the hall, or before you go to different departments, you know, that kind of thing. But even today, we're seeing, you know, masks worn under the chin or hanging or dangling from an ear, or you know, maybe under the nose. Certainly worn not completely in accordance with good principles. So yeah, we are still on that. I will, however, share this. I think you'll find it amusing. I was chatting with one of our physicians here a couple of days ago, and he was kind of busting my chops a little bit. He says, you know, 6 months ago, if I'd have come out in the hall with a mask on, you'd have busted me for spreading disease. Today, if I don't come out with a mask, you're busting me for spreading disease. So which way are we going to go here? So, yeah, I agree with you that familiarity sometimes produces or leads to laxity. Sherry, do you have anything on that?
So I had an experience right after Wood River opened up. After we were closed for 2 weeks. I went up to help them set up their COVID unit. And the ED physician, who had just returned from illness, COVID-19, says, "Are you going to tell me I told you so?" Because I was always fussing them about not putting influenza
patients on isolation until they had a positive flu. And I just said no. I think my mic stopped working. Is my mic still working?
Yep, you're still working.
We were getting some feedback, so I muted Dawn while you were talking, Sherry. Another lesson I think that for me through this, because my career I've been through SARS, the original SARS, and H1N1, and the Ebola. This time the national stockpile was not there for us, and you mentioned that in your presentation that we probably need to reevaluate our stockpiles within our own organizations, and we were always told that that was going to be ready for us, but it wasn't, unfortunately.
No, that's exactly correct. And you know, if you listen to the mainstream media, there's all kinds of theories or reasons why that didn't happen. But the reality is it's out of our control and it wasn't there for us. So I think in terms of moving forward, you know, identifying what is in our control and what can we do is going to be absolutely key for our readiness plans.
And one thing that really helped us is, like I mentioned, we had our Ebola PPE reserves, and in that we had N95 masks. We had like 1,100 masks
that we had stocked away for Ebola. So that was really useful. And also we had PPE kits that were dispersed throughout our clinics. So we recalled all those PPE kits and took the pieces out of them that we needed. So I think it really is important to have your own stockpile and not to just rely on community or government stockpiled equipment. What can we store? What has long out dates? And just evaluating that all the time.
We do have some questions. Oh, go ahead.
This is Trent with St. Luke's. I just have maybe just get your thoughts on something. You know, as we've seen the pandemic progress, what we haven't necessarily seen is, you know, after that initial surge of cases in Wood River, it seems to have really leveled off and be very low levels since then. Whereas we've seen other counties like Canyon County kind of just start to creep up and continue to see cases to the point where, you know, Ada and Canyon County seem to have this steady flow of continuous cases. And so I'm just wondering if you have any thoughts on that, if it's kind of a community reaction from that initial surge that was really a shock and awe effect that kind of made the community take it more seriously than maybe the response has been in the Treasure Valley. Do you have any thoughts on that?
I do have lots of thoughts on that. So I think it's a couple different
things. I think it was the shock and awe. I think there was, we didn't know what to expect. And at the first, they were putting a lot of patients on ventilators, which really pushed the capacity to our ICUs, where now with treatment, they have more options for treatment, and they're backing off of that practice and not putting on patients on ventilators unless they absolutely need to be. And I think as people realized it wasn't as deadly, a lot of patients aren't even getting tested. So I think that's part of it. I don't know, Dawn, do you have any other thoughts?
Now, thank you. I can tell you that the communities up in the Wood River Valley have really taken some of the lessons to heart. And so Ketchum and Haley have their local political leadership mandated masking out in public. Not just a good suggestion, but they've mandated it. As we've progressed through this, the pandemic up to this point, not only those local communities, but the communities between there and Twin Falls as well, have adopted a lot of the universal masking protocols. You'll see a lot of the businesses in Twin that mandate masking before people can come in. Now, that's not to say that everybody wears a mask all the time, because Lord knows that's not the case. But I'm absolutely a firm believer that the masking and distancing and hand washing, those 3 W's that we promote, are also instrumental in helping to keep our curve flat.
And I agree with that. We saw the difference
between Wood River, where we didn't have masking of employees, and we saw what happened. I think we had 44 employees out at one time, either due to illness or exposure. And for a small facility, that was just really hard to deal with. So when we started the universal masking, we did not see that employee to employee transfer of disease with our Magic Valley staff. We had a few staff that in the very first weeks of the illness that did contract the disease, but for the most part, our employees' illness has been very low in Magic Valley.
There's a question in the chat box from Amy Russell. Any thoughts on how we could have gotten around being the interface with the state lab for determining who got tested initially?
Sherry, I'm going to punt that one to you initially.
I don't know how we would have got around it, because that was from CDC that all testing was going to go through the state labs. I do think that was a CDC error in thinking that they could handle that capacity and not getting the commercial labs involved sooner. I think we do need a process built into our emergency preparedness plan, though, of how, if we have to bring on a new test quickly, how we are going to get those results into the electronic medical record, and how we can quickly get reporting on those results, because that was a huge challenge. Because we had positive patients, but we couldn't put it in the patient chart under testing, and so that was a big challenge.
So Amy has put in the chat, she is meaning that IP as the interface. So.
Oh, I think you just can't let it happen. That was my mistake. I've learned my lesson, and I let that happen to myself. I put myself as the go-between between public health and the physicians, and I'm not going to do that ever again.
It's hard because we tend to be the fixers. We want to fix things, yeah. and it's very easy to get drawn into that. And especially when you're in the middle of it, you can't see, objectively. And
thank you for bringing that. Thank you for bringing that up. That is exactly the conversation that Sherry and I had with each other about this. Is that we do tend to be fixers, and we want to address everybody's concerns so we can move on. And being mindful of what our role is and firm on staying in our lane. Once we kind of understood that situation, it really has helped us to deal with many of the challenges that we've had to weigh in on.
Yeah, so Amy saying she totally doesn't disagree, just didn't see a way around it in the beginning, but then it was awful. So I think that was something that at the time that we did have to do, and there was probably wasn't a way around it at that time.
One thing I did do is that we developed like a criteria for physicians in ordering COVID testing, and on that criteria, if they had questions, I referred them directly to the health department instead of my cell phone. I just kind of took myself out of that situation. So we put up a poster in our ED and that telling them how to order a test, what they needed to have to order the test, and who to contact to get permission to run the test. Because at that point, we still had to have approval from the health department to even order a test. And
right.
That was, the physicians just really struggled with that because we knew I think our numbers would be a lot higher in Wood River and Magic Valley if we were able to test all the patients that they suspected those first couple of weeks.
So quite a few people are sympathizing with what we went through. Let's see, don't know where the year has gone. I feel like it's been a full force for COVID in my hospital since February, and I can't do my regular job. That's usually what happens. All the other things kind of get pushed to the side. At St. Al's, we did decide that one person was going to try to do surveillance, and then the other would focus on that, and then the other folks would focus on COVID. I think that's worked well to keep up with our data, even though CMS said that we don't have to report data. So for those of you that weren't able to get surveillance done, you got that CMS waiver. And again, priority, I feel like everything COVID is priority, and basic IP standards are not always what are considered anymore. And this is from Janet. She says she misses her old job. And Louise says, I love the staying in your lane, but this is hard as I am the only IP. Yes, it is when you're on your own. Get your manager to help you. That's my only words of wisdom.
Yeah, and if we haven't expressed it adequately, I'll say it again. We cannot express how grateful we are to have had the team behind us that we did, because I cannot imagine how difficult this would be for a single IP in a facility that doesn't have the resources that we had our disposal to draw from. It would be extremely difficult.
Don, and I think that's a good point. This is Trent again. I do think that, as a chapter, we want to serve our members as best we can. So you can always reach out to the board, and we can either one, answer that question for you or help you in some way, or maybe connect you with people who might be going through something similar and have some good advice too.
Does anyone else have any questions, either through chat or I don't see anything new coming into chat. Oh, Janet, go ahead.
Janet. Hi. Yeah, and thanks for sharing what you guys went through. I mean, it hasn't been fun for any of us, but one of the things I'm coming across when I said, infection prevention standards is like everybody else is the expert now, and you're like trying to say, wait, and everybody's like, no, this is what we do now, and this is what, it's just driving me nuts. But are you guys getting a lot of pushback where people are wanting wear, they're wanting to wear hospital scrubs. They're wanting to have gowns for everything. They want to have their hair covered. They want to, I mean, it's like everything has to be covered completely. I don't know. It just feels like it's just so overboard. And then they're wearing the scrubs home, and I don't even know what's going on. It's just so crazy. I feel like I just lost control on so many things.
No, I
How are you guys
absolutely,
dealing with that?
I absolutely can relate to that, because we have had some situations where we've had kind of addressed some of those issues. Again, back to some of the resources that we've had at our disposal, our system made it available for those who were in frontline patient care. If they wanted to wear hospital scrubs, they could, but we also put into place mechanisms to make sure that the scrubs were being properly removed and laundered, not taken home, so on and so forth. Kind of along that line, I am absolutely convinced that as an IP, one of my main responsibilities is education. And that has been probably, I don't know, 45, 50% of our time has been spent in education, both just-in-time coaching, mass education to folks on PPE use, updating everybody with the changes in PPE requirements. How do we go from what is euphemistically being called normal situation to now an extended use protocol where we're using the same mask between patients, and just that ongoing education. And so I do feel your pain in that respect. I'm going to ask a question kind of in return, and it's a somewhat rhetorical question, is how many of you feel like or are staying awake at night worrying about when we do kind of get back to a sense of more normal, like where PPE is a single use item, that we're going to have to go through all kinds of retraining to break some of the bad habits that we've trained to during the pandemic.
I totally agree with that, Don. Yeah, I worried about that myself.
Yep, absolutely. Well, I don't think we're out of the woods yet for supply. I mean, at least we're not with HCA. I'm hearing about glove shortages. I'm hearing about duck bills. We're running out of those N95s. And a lot of people are wearing them because they like them better than the 3Ms. And I agree, they're more comfortable. But, just I don't know if life's ever going to be normal again.
That's the other side of the nightmare, right?
Right. Yeah, and in the chat, Amy Russell's saying that she's doing more talking down people down off the ledge than encouraging IP practices sometimes. I think we've all done a little bit of that as well.
Yep.
Absolutely.
And I'll come back to one of the comments I made during the presentation, and that is the message that I've been trying to share with everybody right from the beginning, and is we've got this, right? Infection prevention principles are principles because they're foundational. We practice this day in, day out with just our normal care of the patient. We have patients on respiratory precautions. Why? Because we know how to interrupt the transmission of the disease. And so I try to reinforce that at every opportunity with the folks on the front line, so that they kind of make that connection that we know how to deal with this. It doesn't matter what the name of the bug is, or what we're dealing with. If we adhere to the principles, we will safely treat our patients and we'll keep ourselves safe.
Absolutely. Well, thank you, Don and Sherry, for this wonderful presentation today, and everyone that's listening for the questions and the chat questions as well. I think this has been a great learning opportunity for all of us, and also an opportunity to just kind of share the pain and feel for each other, have a little compassion, right? So, all right. Well, with that, I will end the presentation. And it is being recorded, so we'll try to get that on our YouTube site if there's anyone that couldn't attend today.
So awesome job from Amy Russell, Don, and Sherry in the chat box.
Thank you.
All right, everyone. Have a great afternoon.